So let's start out. I'm going to talk a little bit about bioethics and what it is and where public health ethics and research ethics and ethics fits in. We'll talk a little bit about what public health ethics is. I'll talk about the moral governance of public health, and then a little bit about the decision-making tools we use to make tough decisions when values conflict. And then I'll talk some about what, from my perspective over 30 years in this field, thinking about what are the kinds of skills that all public health professionals need in order to do their job well. So some would say they need to know EPI, they need to know how to do analysis, they need to know how to create programs, they need to know how to engage communities, and I say they also need to know how to make ethical decisions. So I'll talk about all that. So let's talk first about the, kind of where public health ethics fits in to ethics. So this experience that you all are in, you're dealing a lot with research ethics, right? So research ethics is a kind of, framework that helps you decide what the right thing is to do when you're doing research. Bioethics is kind of an umbrella term that has anything to do with like biology and philosophy, right? We put those two things together. So medical ethics is clinical ethics, right? We have legal ethics that play a role. I want to start by outlining the different kind of contours of each of three kinds of ethics. I'm going to start with the research, go to the individual clinical ethics, and then talk a little bit about how those two are different than public health ethics. Please interrupt me at any time, and I like this to be a discussion. So first, I'm going to talk a little bit about who we care about, who we are doing the should stuff for, who benefits from the activity, what our approach to action is, and then hence what are the ethical concerns. So let's think about what you all have been thinking about for this whole year and probably longer. Research ethics. Who do we care about in research ethics? We care about the research participant, right? We want them to be able to make their own choice about participating, to be able to quit whenever they want, to make sure we reduce the risks for them, et cetera. Our approach to action in research is some experimental design or observational data collection. We're trying to look at a particular cause and effect, et cetera. Therefore, our concerns, our ethical concerns, many of you, I'm sure, have read the Belmont report or submitted something to an IRB. So you know about these things. We're worried about ensuring that people actually claim their own place in research, that we're not forcing them to do things. We worry about privacy of their data and confidentiality of their data. We worry about protecting vulnerable folks as well. Our goal, our ethical concern, our primary goal in research is to maximize benefits and minimize harms. And then ultimately, we're very concerned, especially in the work that you all are doing, with the equitable distribution of burdens and benefits of research. So that should all be very familiar to everyone. We also, when we talk about clinical ethics, the middle column here, this is something that we all know from our own experience. We're patients. We all have gone to a healthcare provider at some point in our life. And when we're sitting there across from a healthcare provider, we want them to be concerned with us. My provider's telling me something about some drug I'm going to take. I want them to be clear about how that's going to affect me as an individual. The person who benefits from that interaction is me, right? The approach that we take when we think about this kind of thing is, treatment, some kind of intervention. We don't go to the doctor because we feel great. We go to the healthcare provider because we don't feel well, something's wrong. So it's a treatment intervention, getting us back to baseline. So of course, we're concerned with individual liberty, with my ability to say, no, thank you, I'm not going to take that drug, or I'd rather have high blood pressure than to deal with these side effects. The healthcare provider is trying to do good, the most good possible, trying not to hurt you. And there's a little bit of concern about distributive justice, but that's, to me, more of just a word that people say in clinical ethics and don't actually understand very well. Let's compare these two with a very different setting, and that's public health. So who are we worried about in public health? Well, our patient in public health is not an individual. It is a community or a population. It is the community and population that we are the people who are trying to benefit, or the group trying to benefit. And we use totally different approaches to action. We're concerned with prevention. We want to get to people while they're well and help them stay well. We do that by not necessarily giving people individual medicines or individual treatments, but by doing things like having policies, by sanitation measures, by behavior change interventions. Very different than the treatment, medical intervention, or the observational experimental approach. So our ethical concerns are different. We, of course, want to respect persons, communities, and populations that like, dignity matters in all of these. But we are also concerned with interdependence, relationships, interrelatedness, and the social good, which here would be health. We're really interested in avoiding social and community harms. Group harms are a huge concern in public health. Not so much when you're going to the doctor. You care about what group you are in or whether there's going to be harm. That's just not on the radar, and it's rightfully so now. And then also the foundation of all public health is social justice, right? We care about people, we care about justice, and that is our foundation. So because these are very different, who we care about, who benefits, what our approaches are, and how, what we're concerned about ethically, we have to move from the focus on the individual person or patient that we focus on in research or clinical ethics to the group. And this is a mind shift that's tough for some people to make. Other people are naturally drawn to it. And some of you are like, yeah, I've known this forever. But for some people who are very rooted in that individual orientation, this can be very hard, especially because the heightened focus on autonomy in clinical ethics over the last 50 years, no longer does the, old doctor with the bag come in and tell you what's good for you. You don't have to understand and don't worry your pretty little head. Those days are gone. Now you have patients who come in and they say, I've done literature review. This is the latest thing. I would like this medicine. I would like that thing, and I'm going to take control of my treatment plan. That autonomy is super important in clinical ethics, but it's really incompatible with the health needs of a population. And so we have to think about. At first, when we were thinking about public health ethics, we were trying to put this square peg in a round hole. We were thinking, okay, how do these four principles, autonomy, beneficence, non-maleficence, and justice fit for population health? And it didn't really work very well. So and one of the reasons it didn't work very well is the public part of public health. We are dealing with a public good. And so we have to shift from this very individual orientation to a collective orientation, meaning that we have to shift from our individual moral compass to our profession's moral compass, to what the profession values, what professional ethics are. And because we are making decisions not for our own care, but for the care of other people, we have to focus on an ethical decision-making process. And we'll talk a little bit more about that in a second. So given these differences and these different kinds of contours of individual clinical ethics and research ethics and public health, we define public health ethics differently than we define something like clinical ethics. I define it in two ways. First, public health ethics is a noun. It's the moral governance of what we do. It's the group of values that we care about in public health. It's what motivates us to do our work. It's our values, including things like equity and respect for human rights and community engagement and honoring lived experience, the common good, these kinds of things, solidarity and justice. And because public health is public, we've got to consider the merits of lots of different kinds of values because we live in a pluralistic society. If we asked everybody at this table, what are your top 3 values? They would be different from each other. We would be different from each other. So we have to recognize that while there are some common things everybody values, we can probably say there are 4 or 5 things that everyone on earth values. There are differences in how we define living our best lives. And we have to be able to honor that in our work. The second aspect of public health ethics with respect to its definition is a verb, and that is reasoning or making decisions for our public or our community. This way, this is extremely important when we have ethically challenging decisions. It's not, you don't need a huge decision-making process to figure out, how many rolls of toilet paper we're going to put in the bathroom each week. We just do the math, put them in there, we're done. But if we're going to say, a decision about where we might locate a harm reduction center, there's a whole bunch of conflicting values there, and we have to get them out and reason through them. And so when we apply this decision-making framework, then we can determine a course of action and figure out how to resolve some of that tension between the things we care about. It is important to remember that in public health, often we're not deciding about between two things. This one's right, this one's wrong. We're often deciding about, here are 4 options for us that are all okay or all good. Each one has its pluses and minuses. Which of those are we going to value, and how are we going to do that? What's the moral valence in each of those situations, and how are we going to decide the best way to go right now, given what we know? So that is a critical point. So a great example from COVID is, like, how do we decide in public health whether, from in the COVID days, still in, how do we decide whether we should close business or close a downtown or close a shopping mall or close an entity? We have to weigh the value of health with the value of economic health, right? Physical health and economic health. Both are important, both matter, and we have to figure out what to do there. And so we need a robust and transparent mechanism to reason through it. So I think it's important for us when we think about reasoning and making decisions and all the values we have to consider, that our decision-making has to be as transparent as possible. And that's where all this stuff comes in that you all have been doing, right? Engaging your communities, understanding the lived experience of the people for whom you're making policies. It might not be for you, but it might be for people that you serve, and we have to understand what they're all about. So let's talk about the definition now of public health. So I said it's 2 things, right? The moral governance and the decision-making. So let's talk about the moral governance. What values motivate our work in public health? Whose values motivate our work in public health? These are the kinds of things that we have to think about. We have to recognize, as we said, that, we are making decisions for other people, and we are all operating in communities that are incredibly diverse. Even our own little community that's diverse from everybody else. Within that community, there's variety as well. And we have to be able to think about what are those, how do we identify the common values, those things that make sense for everyone, while we understand that there are many versions of living our best lives. We share this planet with 8 billion other people as of a couple of weeks ago. Congrats to us. We have increasingly small world with respect to being able to be in contact with those 8 billion people. So we have to consider a lot of different things with this. And one of the important things that we have to do, as I mentioned, was move away from what our personal moral compass is to what our profession's moral compass is. And how do we know what the heck that is? Well, basically, what we have to do is find out what that is. We have to engage our communities. We have to ask them about their lived experience. We have to understand our communities. We have to go walk into and share our experiences with our communities. The important piece here is that public health providers, public health professionals face hundreds of ethical decisions every year. And when you ask them, how did you decide which one to do? A lot of them say, I just knew in my gut, that's what we should do. I just know what the right thing is to do. This is what my grandmother told me is important. And that is a dangerous place to be, because that's a person's moral compass, not the profession's moral compass. So making the switch from what we think is the best, what I think is the best thing to do, to what does our profession think is the best thing to do, is critically important and the basis of all the things we do in public health. This reminds me of a quote, something that somebody said to me once. I was at CDC and we were in a animal care and use assessment. ALAP is the international organization that accredits research institutions that do research with animals. And at CDC, we do. And we were in our exit conference, and we were having I'll say heated debate, an intense discussion about two different veterinarians disagreeing about care for a particular species. And this quiet, smart, subdued, observing gentleman said this amazing thing. He said, professional judgment is the judgment of the profession, not of the professional. And I really think that applies to ethics too. our ethics, our judgment about what the ethical thing to do is not ours alone. It is our professions. And so how do we figure out what our profession, whatever that is, in this case, public health, thinks is the right thing to do? So if you need an example of like what I think is the right thing to do going wrong, think about Dr. John Cutler. How many of you have heard of Cutler? All right, John Cutler, a dashing young physician in the US Public Health Service in the early 1940s. He is the mastermind behind the syphilis experiments in Macon County, Alabama. Some of you might have heard this called the Tuskegee syphilis experiment. This experiment in Tuskegee was an experiment fully based in racist medicine, which was based on his belief and others at the time that that syphilis affected white Americans differently than it affected Black Americans. And he really felt like it was a scientific question to figure out how different those things are. And so he went with a bunch of his colleagues into a rural area in Alabama, recruited about 399 sharecroppers, many of whom had syphilis and some who didn't. And he set out to observe them for 40 years. During that time, he ensured through lots of staff and lots of effort that none of those men who were infected with syphilis got treatment. And at first in the 30s, the treatment was bad. It didn't work very well, but it did help. But he still withheld it. In the 40s, when penicillin became freely available or widely available and very cheap and a 100% cure for syphilis, he also withheld that from those men. So his study went on for 40 years until a US Public Health Service public health advisor got wind of this in the 70s and said, this doesn't seem right to me. I think there's a problem here. And the study was ended. There was a huge effort to think about how to compensate and fix what ended up being unethical experiment, not just by our current standards, but by the standards that were in place at the time. He also, during that same time, conducted the Guatemala experiments. Is anyone familiar with what happened in Guatemala? So Guatemala, he went again to a vulnerable population, people in prison, sex workers, and people in psychiatric care. And this time, he wanted to learn about how contagious syphilis was. So he infected some of the prisoners. One would say, how did he infect prisoners? I mean, isn't syphilis a sexually transmitted infection? What, he went in there and had sex with them? No. What he did was abrade the skin on the head of their penis and inject syphilis spirochetes into the urethra. So he did all the stuff he could do, right? And then he brought in sex workers who were negative for syphilis, had them have sex because this was legal in Guatemala at the time, and then was looking at how transmissible it was. This went on for only a year. And it only went on for a year because he had a little bit of an inkling that maybe this wasn't the right thing to be doing. He didn't want anyone to know about it. And so he stopped the study after a year. All the time, and even 20 years after Dr. Cutler finished his experiments and was far retired, he held firmly to the belief that what he was doing was scientifically valid and scientifically important. He was convinced that this was the right thing to do because he felt that science needed to know these answers. He was wrong, but he still did it. So the question is, if we have a context, some guardrails for people in the field of public health, would that have helped him maybe not have made these decisions? Who knows? We didn't have them then, but we do have them now. And this, in large part, the field of public health ethics grew out of this kind of malpractice, also called, this is what I believe is the best thing to do. So it's easy to see how that can go bad pretty quickly. he has since died. And he did, as I said, go to his grave thinking he was doing the right thing. So for the past 25 years or so, public health ethicists have been thinking about like, what is our field, what matters to us, what motivates our work? And we've come up, lots of really famous people, many of probably who you've read, have developed frameworks for this is what it should look like. This is what we should do if we're going to, this is how we honor autonomy while still worrying about the greater good. Lots of different things, all based on a set of values that we have in public health that include both liberal concepts, and I don't mean politically liberal, I just mean like, things like I have human rights, we don't want to interfere when we don't have to, individual liberty matters, we have to respect people and ensure that communities, vulnerable communities that are at risk have compensation for their increased risk and mitigate that risk. And then some collective concepts like the health of every human being has to do with the health of every other human being. The health of the ecosystem has impact on the health of humans. So lots of community benefits, things like community harms, bystander risks, justice, transparency, these kinds of things. So lots of people have thrown out these different kinds of concepts. And over the 25 years, these have been building, and everybody calls them something slightly different. And these are all these different kinds of things that we call our collective values of public health. So the American Public Health Association thought, maybe we should think about like how to take all this stuff and put something out there that says, here's what we value as a profession. And we did that in 2015. The American Public Health Association set out to create an ethics code to outline the ethics of public health. We wanted to do three things. We wanted to outline what the basic values of public health are. What are the ethical considerations for making decisions and deciding what to do in public health? And then provide a model for complex decision-making for those public health workers that are out there in the field trying to decide what the heck to do every day. Our team included Dr. Fisher and included Dr. Faith Fletcher, who I know you all met earlier this week and is a colleague of ours in this field. We spent over 4 years doing a huge sweep of all different kinds of public health professionals, laboratorians, environmental health people, restaurant inspectors, infectious disease epidemiologists, chronic disease epidemiologists, everybody we could think of in public health, local, state, federal, international. What we wanted to know, what do you think are the important things that motivate our work? And while it took us 4 years to go through this deliberation, in 2019, we actually ended up publishing this thing. And this now serves as our kind of fundamental go-to, what do we value? How do we make decisions? Now, I want to mention a quick note about many professions, in fact, almost all professions have codes of ethics. So physicians have codes of ethics, nurses, epidemiologists, and Society of Epidemiologists have research, anthropologists, whatever your discipline is, your discipline has a code of ethics. There is a difference, though, between a code of ethics and a code of conduct. So most disciplines call their code of conduct, you can do this, you shouldn't do that, you must do this. They call that their code of ethics, but that's not what we did in public health. Instead, so for example, the health department that I work with in Virginia, here's their code of ethics. You have to negotiate contracts, you have to avoid conflicts of interest, you can't give gifts or receive gifts, you have to report somebody you're suspecting is doing something wrong, you have to address misconduct, you have to protect the financial assets of the state. This isn't a guide to how to act ethically in public health. No, this is like, do this, don't do that, right? This is the list of rules. In the code of ethics for public health, we wanted to say to the world and to each other, this is what our profession values. This is what you can expect from each other and the world, communities. This is what you can expect from the field of public health. So that's why we decided to outline specifically what our values were, what we go into every situation on, what is our foundation of every decision we're making? What are those ethical lenses we bring? And the first of our core values is professionalism and trust. Now, these are not in any order. I tried to just list them with ABC instead of 1, 2, 3, but somehow you got to put them on there. So professionalism and trust is so important because the currency of public health is trust. Your communities don't trust you, they're not going to listen to you. Anyone remember the mask debacle, right? Anybody remember people who don't want to get vaccinated for COVID-19? No trust equals zero currency in public health. So for us to provide this even as a document for people to read increases our trust. This is what we care about. We're being transparent. We know that unless people trust us, the effectiveness of what we do is gone. Health and safety, of course, core value of public health. In fact, it's a core value because health is essential for human flourishing. But it's also what we're legally obligated to do in public health. Public health seems like a bunch of nice people trying to do the right thing, but it's behind all that is a state mandate that we have to take care of the health of our populations. So we're obligated. We can't watch a bad TB, multi-drug resistant TB outbreak happen in a communal setting and be like, wow, that's a drag. We are legally obligated to go and do something about that. So we have to address health and safety. Health, justice, and equity. This is, the basis of everything we do in public health, because we know that in order for humans to flourish, we have to provide opportunities for health and safety. So that's clearly one of the founding values. Interdependence and solidarity. Again, we know that the health of one person is tied to the health of everybody else. If we didn't know that before COVID, my God, we know it now. We should have known that long before then. But it isn't just people. 75% of infectious diseases in humans come from animals. So we've got a whole other group of folks, things, animals, beings that we have to pay attention to. What's the deadliest animal on the planet? Mosquitoes. Kill more people than anybody else. Although we're close. We're close. But mosquitoes, so we talk about public health, we're talking about insects and animals and the ecosystem as well. Human rights and civil liberties. This is a crucial thing. Now, a lot of people say, how can you say human rights matter when you're talking about the good for the community? How can you say you have to respect civil liberties while you're saying you got to be vaccinated or you can't come in, you have to wear a mask or you can't be on this plane? How is that respecting my civil liberties? Well, that's not exactly what we mean when we say this. What we mean in public health is that self-determination and equity are essential for people's opportunities to have health. If you can't determine your own health, then we have no freedom or ability to make decisions. We have to be able to make decisions in the absence of domination. This is particularly important for historically marginalized folks, which includes everybody who's not a white cisgender male, right? So we have to be thinking carefully about how to balance this idea of, groupthink and the tyranny of the majority and the civil liberties of every single one of us on this planet. So it's a delicate balance, but this is not, I have a right to go into a busy airport and cough on people if I have COVID. As your civil liberties end where another person starts, right? So that's a more complex than it sounds, but it's a critically important piece. And then finally, inclusivity and engagement. Again, we do work for other people. We make policies, we create interventions, we do a lot of things in public health that aren't for our own benefit, they're for the benefit of our community. We have to know what that community is, what it values, what it cares about, how it works. So a lot of us work from our university desk or our home office desk, and we might never have walked in the neighborhoods of the folks on whom we're conducting research or conducting some kind of public health engagement. And it's really important that we understand the lived experience of the people we're going to affect. That's something that we've learned the hard way 1,000 times. We'll continue to learn the hard way 1,000 times because we're not so bright in that respect as humans. But ensuring that we know what it means to communities to flourish. If I say to a community, what you need is to go to college and get a great job so you can have a car and go on vacation every year. But that might not be at all what that person or community thinks is a good life. So we really have to understand that. So, you know, this set of values really represents our profession's moral compass. This document tells the world, this is what we care about. This is what we're going to think about when we're doing our work, rather than my own personal moral compass, which is, you know, hey, I really think that whatever I think, it doesn't matter. Not important. You can have that and do that and honor that in your own life, more power to you. But if you're going to be a public health professional, this is our moral compass. So we think about these, and we think about teaching people who do public health about these values, because these should be infused in everything we do. It shouldn't matter if I am a clerk at an STD clinic. I should be thinking about this. If I am the healthcare provider doing, you know, the directed observed therapy for TB, I should be thinking about all this. If I am creating interventions for overweight and obesity in communities, I should be thinking about these things. We all should be. The reason we took the care to separate safety is because we, over the years, have heard a lot, especially when I was at CDC, why do you guys have an injury center? Like, what the heck, who cares? You know, like, why is that public health? People fall and break their hip. Well, it's a safety issue that impacts health. So a person might be very healthy, but 98 years old, fall, break their hip. That's it. So safety is a different kind of thing. We also, but part of it is that we know that physical safety is different than traditional health, right? When you say health, people think about like, oh, how my body works. But if you're shot in the middle of a supermarket, you're not sick, you're not safe, right? And so we really wanted to emphasize that health has a lot to do with being safe. Exactly that, we're weighing all of these, and it's not like clear all the time, right? So yes, the liberty of someone to say, I don't want a vaccine, that is fine. People don't have to have vaccines, but they don't have then the right to infect other people with whatever they're not vaccinated against. So it's really a matter of weighing all of this stuff. And in every situation, the weighing is different, depending on what the harms are, depending upon what the potential risks are, depending upon how severe the outcome is. You know, would I, if I don't know, if there was a vaccine for stubbing your toe, would I make everybody get that for stubbing your toe? Of course not. I mean, you don't want it, then stub your toe all you want. But you're not going to make anyone else stub their toe. So it really depends on the whole situation. And this is where, which is a great lead-in, where making decisions about public health action, that is part of the definition of public health ethics. We have to have a tool or some tools to consider all these things and figure out what is the right way to go. So we include not just what is our moral governance, but how do we use that moral governance to make decisions about what we're doing. So let's consider a few things. So public health officials face hundreds of ethical decisions every day. They don't often identify them as such, but they do face them. So, let's think, for example, often we hear from public health professionals, oh my God, it's so political. Public health shouldn't be political, but it's political. It is political because it's public. That's just the bottom line. And so how should we approach managing political interference, which we saw plenty of in COVID, that influence on public health decisions, especially in the case of COVID, where that interference costs lives. What should we do, for example, when an elected official directs us to remove certain content, prevention content from our websites? Does that ever happen? Yes, yes, and yes. It's happening in my own state right now, where our governor just recently directed the health department to take off all LGBTQ plus resources for children in our websites. So this will cost lives. This will have implications, right? What do we do about that? If I'm sitting there and really believing as an advocate for social justice that I need this stuff to be on my website, if I'm a health officer, what the heck do I do? How do I manage this? I can't say, well, damn it, I'm putting it up there even if I get fired, because you'll probably get fired. And then what's going to happen, right? So it's not, you can't just do this kind of knee jerk. You have to think through the whole thing. It might end up after you think through the whole thing, you leave it up there and you get fired, but you have a plan, right? Or you know why you did that. So a couple of other kinds of things that we think about in public health. Should we turn down funding that helps us, a screening or diagnostic program, but we don't have any resources to treat it once the disease has been discovered? This happened in some jurisdictions that were taking cervical cancer and breast cancer screenings into low-income areas, but they had no resources to treat, to help women get treated. They said, well, congratulations, your test is positive. We can't really help you. But we hope you can get treated. Like, is that okay? How do we do that? What do we do to weigh all that conflict? Is it important to diagnose? Yes. Is it important to treat? Yes. What do we do when we can't do both? Should we provide free vaccines to people who can afford to pay? So public health is poor. In case of those of you who aren't in public health don't know that. 97% of spending for health goes to treatment after we're already sick. 3% goes to preventing that 97%. So we're poor. And so we don't have just money to, throw stuff away. If we're giving free vaccines to people who can afford them, that means automatically that we are not doing other things we could do with that money. Is that okay? We don't know. In the case of COVID, free vaccines, free and easy vaccines, critically important. Why? Because we needed the rollout as quickly as possible to try to reach herd immunity. We didn't get that, but we were trying. And so we said, we don't care. Put it out there. Should we do that for routine things? A lot of people say no, that we shouldn't. We should use that money for other things. One that's come up recently with the advancing in wastewater-based surveillance during COVID. Should we be testing wastewater for metabolites of illegal substances, opioid use, for example? Where I come from, in the middle of the Appalachian Mountains, we have a huge opioid problem. Huge, like enormous rates of overdoses and deaths from overdoses. Should we be looking at that? What does that mean? We're going to go to somebody's house and say, we're going to test your well and, your septic system. And if we find this, then what does that mean? But I don't know. We're going to call the police. Are we going to, what are we going to do? Like, what are they thinking we're going to do? So these are hard things. There's no easy answer to any of these questions. But what we do know is that in public health, we act. We are not a field of sitting around looking at stuff. Wow, pretty graph. Isn't that cool? Wow, that's really interesting. We actually have to do stuff. And so when we do stuff, we have to do more than just say, this is what my grandmother would do. This is what I think is important. We have to do a number of things. We have to consider evidence. This is what we can do. What are we able to do? And evidence-informed decision-making in public health is essential. We used to call it evidence-based decision-making, but we've moved to a softer evidence-informed because what we can do is not always what we should do. So we learned the hard way in our field that this is not the answer to public health action. This is one important piece. Another important piece are public health laws. These laws in states tell us what we were obligated to do, what we're required to do, and things we're not permitted to do. So we have to consider that too, when we're deciding what action we're going to take. We have to consider ethics and values. What should we do here? And this is where, if you look at public health training programs, you hear a lot about this. You hear a little about this. You hear nothing about this. So this is my mission for my life, is to get ethics infused into the curricula so people understand what's going on. And finally, and really importantly, we're a long time in coming to this, is we have to understand affected communities and their lived experience, because whatever we offer, it won't work unless affected communities are into it. So we have to know what that looks like. We have to understand lived experiences, because the collateral damage that we inflict by not doing this will cost us that professionalism and trust. And in the future, it takes a long time. And what's that saying? It takes, you can do 100 right things, you just do one wrong thing and trust is gone. That's so the case in public health as well. So we've got to consider all these things. So how do we consider all that? Well, because they're not my values and what Lisa thinks is right, we have to think about how to incorporate think about a process that will incorporate everybody's. And that process is called a deliberation or a deliberative decision-making, somewhere where people can come to the table and give their perspective, and everybody can agree that what we're trying to do here is find a path forward. And so we call that democratic deliberation. There's a huge literature on it, and we've done a lot of work on that in public health. But using a deliberative process, we can ask ourselves, is what we're proposing an approach that ensures that public health is not using their authority, their legal authority, right? Because we have that in states, in a way that's arbitrary or discriminatory, right? We want to be able to have this kind of open conversation so we can ensure public trust. So if we attend to these 8 or so considerations, this can really help put our planned action through some ethical scrutiny. Let's start with permissibility. I'm going to decide I'm going to put, do a public health action. And I ask myself first, would this action be ethically wrong, even if it comes to a good outcome? So is it permissible? Is it ethically okay for us to do this action? So one example of this is, if there's COVID, there's a correctional facility in Pennsylvania, they did wastewater-based COVID testing. As long as there was any COVID in the wastewater from the correctional facilities, all prisoners were on a 23-1. Does anyone know what that is? 23 hours of isolation and 1 hour out in the yard. They were not allowed to have any medical visits, any lawyer visits, any visits with families. Okay, well, we can do that, and that will probably reduce COVID in that correctional facility, but is it permissible? Is it the right thing to do? Well, some people say, well, if it prevents the disease, sure. But here's the catch. The wastewater is all people who use the restroom in a prison, which is prisoners and correctional officers who are going in and out, potentially bringing COVID. It might be their COVID. We don't know if it's prisoners' COVID. So clearly there's some permissibility issues associated with that. So we have to think about those things. Think beyond at first blush. Respect, would this action be demeaning or disrespectful? In the prison example, yes, demeaning and disrespectful. Now, is that always a no-go? No, not always, but depending again how severe the harm is. We don't let our 3-year-old run out into the street. It's disrespectful to yell at them in front of everybody else in the middle of a busy street, but it's worth it because otherwise they might get run over. So we have to, it's all things considered we're dealing with here. And the next thing we want to think about is reciprocity. What is reciprocity? We all think we know what it is, but then how you put that in words, right, is a little challenging. In public health, it means we're going to ask people to do something. We're going to request that they wear a mask, get vaccinated, whatever. We have to ask ourselves, have we done everything we can to make it as easy as possible, as easy as reasonable for them to comply? If I'm going to ask somebody with multi-drug resistant TB to go into isolation for 4 months while they take their meds, I have a lot of responsibility. I have to make sure they have food, make sure their social and emotional needs are met. I have to make sure they actually have a paycheck, right? Or that they can feed their family, or that their kids at home have a caretaker. I have a lot of responsibility when I ask somebody to do something. It's not always that dire, but that is why we set up vaccine clinics everywhere. Oh, hi, you're in the shopping mall. Would you like a vaccine? You just stop here for 1 second. We've reduced the barrier as much as we can. And that's critically important for getting compliance. Effectiveness. So we talked a lot about how data and evidence are really important in public health. We want everything to be data driven or data informed. We have to make sure that whatever we're asking actually works. Think about the fiasco with mask use in the beginning of the epidemic. Don't wear a mask, it doesn't work. Do wear a mask, it works. Don't do it. People were like, all y'all make up your mind because I'm confused. We have to, say, we think this is going to help. This is before we had data. We think this is going to help. Not positive. We think it is, wear it. When we get evidence, then we say, boy, wearing masks, 2 people together wearing masks helps a lot. We say it's effective, do it. So we want to make sure we keep that we've demonstrated that it's effective. Responsible use of scarce resources. This goes back to the idea that public health is poor and we only have a limited pie, and we really want to make sure that whatever we're doing with our money and our resources, we're responsible, being responsible with the overall picture. This was critically demonstrated with the lack of healthcare that lots of people got during COVID, right? We had people not getting pregnant people not getting prenatal care, not getting great postpartum care. We had people not, an enormous number of people not getting their annual colonoscopy, mammogram, et cetera, et cetera. So we really have to think carefully about that as well. Proportionality, we really want to make sure that what we're doing, what public health policy is asking people to do or creating for people is proportional to the risk. So again, we're not going to make people get the vaccine for toe stubbing because I mean, the risk is low and it's not a big deal. And, people might swear in front of their kids or something, but that's about all the harm you're going to do. That wouldn't be proportional to make everybody do it. Was it proportional to request or enforce vaccine mandates for COVID? Yeah, because it was a deadly disease. So we didn't know anything about it. So that's a different kind of proportionality, but we have to think of that as well. Accountability and transparency. This goes back to the fact that we're making decisions for other people and that public participation is absolutely essential. What is that saying from the disability community? Nothing about me, nothing about us without us, right? So that should be for all of us. I feel that way. I don't want people making decisions for me unless I have something to say about it. And communities feel the same way. We have to be able to respect that. So how do we put all this together for public health professionals? The last section I want to talk about is just this idea. All public health professionals need to have 4 skill sets in order to do their work ethically. The first thing they need to be able to do is identify what the ethical dimensions of their action. If you don't know that your potential policy is going to have some unanticipated harms for your community, how can you deal with them? You have to be able to recognize what's going on. You have to be able to say what's going on. You have to be able to tell your community, we thought about A, B, C. We thought about your value of blah, 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 and this is how we dealt with it. And when we saw that value A and value B were conflicting, this is how we worked through that. So really being able to be transparent. That comes from working together to deliberate a path forward, where we use evidence, we deal with the laws, we include values, and we include lived experience, all those things. And then we, like all excellent public health professionals, we implement and evaluate. We say, was this the right thing? Did we have any, things that happened that we didn't expect that we should have thought about that we can think about next time? Or in the case of COVID, did we get new evidence that then would change the calculus, change the way we weigh all these values? We did that constantly during COVID, and we have to do that with other things as well. So the method or the way we make decisions in public health is reflective and participatory. It's multidimensional. Really, really important to recognize that risks are not just physical risks, they're emotional harms, financial harms, all these other kinds of harms, information harms that can happen to people. And we have to be open to revision as we get new information. That might be new data, or it could be a community saying, we're done with this one. It didn't work. We don't want this one anymore. We want to do something else. And so the question was, how do we communicate this in the world of social media in a hugely polarized world? It is really hard. I don't have a magic answer for this, but I will say that one of the most important things we can think about in public health is just because it's hard, doesn't mean we don't try or do it, right? We have to get to our communities. And one way that CDC has done this and other health departments have done this is hire and train people from communities we work with. So we have trusted opinion leaders, we have trusted messengers, we have people who understand both the public health and the lived experience of the community, and to bridge that. It's a process and it's hard. And I don't know what the answer is. One of the things we must do, though, in public health is continue to do the work in a transparent and ethical way. So if anyone asks what happened here or what did, we can say, here's what we did and here's why we did it. So part of it is explaining why. We all actually never really outgrow that 4-year-old that says, well, why? Can I have that? Why? Why? Everything is why. Like, we have to be prepared to answer that for folks because all of us want to know that. So thinking about messaging. And so when I say multidimensional, it's not just the people who know the program, know prevention, know EPI. It's people who know communication, people who know how to get communication or to get information from affected communities. It's all the things that you've learned that Dr. Fisher was talking about with the goodness of fit ethics, right? You've got to get in there and figure out what fits in this situation and be able to communicate that. Yet, even if you don't do public health,
Right.
your work will influence public health action. Because you're working with these vulnerable populations and you're providing evidence, possibly some affected community evidence, what I like you're doing qualitative, you're telling the public health official, here's some information about lived experience. So all the things you said are just said right now are about the individual subjects of your study. But I think what Dr. Fisher is asking you is, let's take that lens up 50,000 feet. What would the results of your study do for public health action? And are you considering that now so you can talk about that in your study, in your discussion or your study? Because if, for example, I'm sorry that I don't know the details of your study, but if you're doing something asking like, how would you feel about your partner getting pregnant? And the male partner says, well, that's ridiculous. I shut her out and leave the kids and, whatever, like I create some bad outcome for them. That's a really important thing for a public health official to know. Because if they make a policy and then a whole bunch of pregnant women get hurt because of the policy, we need that information. So it's less about like, are we thinking, so you're in very much the research ethics thing, and really public health ethics is really about like, what are the implications of your findings? Or, what are the policy implications of your finding? And what do you need to tell public health officials about your study? This is really important. These were our findings. However, it was in this group of people, not in everybody, or it was in, it could be that kind of issue, or it could be an issue of, they said it would help, but they said this bad outcome might happen and we have to be aware of that. So we can help. So all of you in your work help guide this policy. We do have some protections of that, like public health officials, in public health data, they're protected in a way that study data and clinical data are not. And in large part, that's the case because of this idea that, there are benefits to more than just the individual. So, but that doesn't mean that somebody couldn't read your paper and go, what a brilliant idea. I'm going to do that to harm like a police department if they could have the money or the, resources to do that. Public health officials, because of their legal obligation to protect the health of the population, they operate under a different set of public health laws. So I could go out into a community and say, okay, I'm going to do this for public health surveillance. Your data, can't be shared. If there's a subpoena, it can't be subpoenaed, it can't be shared with anyone else besides, us in the health department, blah, blah, blah. That's fine. You go out as a researcher and say, I'm going to collect this data from you. Same thing that the public health person just asked me or asked you without all those protections. So for people who are being asked for that information, they don't know the difference. They don't care about the difference. They're just like, all y'all don't have my data, right? So I think it's really important that we recognize that public health has this special designation about what they can and can't do with data that's different than researchers and different than healthcare providers. So it's tricky, but if somebody's data are breached, it's likely, well, it's never happened from a public health surveillance system that data have been, people have been harmed from a breach, but it has happened from research data, from clinical data, from insurance data, those kinds of things. But to the person whose data are breached, it doesn't matter to them who did it, right? It's the fact that their data are out there. So it is a very tough thing. And this is why it's so important for the field of public health to have a cornerstone, a touchstone of what our values are. So when we get in a situation like that, we're like, wait, how have we gotten here? We can go back to first principles and say, Jesus, this was the wrong thing to do, or we got to move this in a different way, which people came to during the Guatemala experiments. Yeah. But, obviously way too late for a lot of people. Coercion means that if you don't do something I say you have to do, you will be punished in some way. So fine, hurt, embarrassed, but like you will receive a bad consequence for not doing what I say. That's different than incentive, which is if you do what I say, I'll give you some treats, right? So we incentivize our dogs, for example, right? Here's Sid, here's a treat. We incentivize people to get vaccinated. Here's so easy, come right here. We'll give you a gift card to the grocery store, whatever. But coercion has generally caused both research ethicists and public health ethicists, here on the back of the next, do we want to punish people for not doing what we want to do? Well, it depends, because think about a person who's not taking their directly observed therapy for tuberculosis. I just had a case recently, person refusing treatment. What do? We, as public health officials, have police powers to enforce a cease and desist order, and we put that person in a treatment place where usually it's a jail, and they have to either take their medicine and get cured, or they have to stay there until they're no longer infectious. That is coercion. That is, if you don't do what I say, something bad's gonna happen to you. We have to do that sometimes. But remember proportionality? We don't do that for the stuff, the toe vaccine. You wouldn't say to someone, if you don't get this vaccine, we're putting you in prison. That was completely, so there was a long time where coercion was just not on the plate. But we also know that we have to do that sometimes. Generally people don't like to do that. The Public Health England or UK Public Health has this intervention ladder where you go like the least restrictive and you keep going up until you have to do the most restrictive. And that's what most public health professionals look at when we get to that idea of, are we going to have to punish someone for not doing something? We have to try everything else first. And context matters a lot. So even in one situation where somebody's not taking their TB meds, it might be different than in another situation. So there's also this idea of fairness and justice, and how do you do that? It's really about, are we treating people equally, or are we treating people equitably, right? And so that there's a difference between what's equal and what's equitable. So somebody might need more threat of for a bad outcome or a bad consequence to do what they're going to do than other people. Like if you told me I was going to go to jail if I didn't take my TB meds, I'd take my TB meds. Thank you very much. Some people know, and so you gotta work up that ladder. But so to answer your question with respect to what public health ethics thinks about it, it's a last resort, but it does need to happen sometimes. And we have to use it judiciously, and we have to consider all the other things as well. Public health has prided itself in my 30-year career in public health. We prided ourselves on doing excellent work in the background. You don't know we exist until something goes wrong. We're doing such great work, you don't even know we exist. And that has been to our detriment, sadly. We're changing that now, but people, I still go and, do talks about my area of specifically public health ethics of expertise in public health surveillance. And I ask people, how many of you have had, the flu last year, several, 25% will raise their hand on. How many of you have been reported to your health department? Raise your hand again. All of you have, what? They know I had the flu, people still don't know that public health reporting happens. And I say to them, like, how do you think we know how many cases of flu there is in our community? Do you think, where do we get that information? Right? So it's amazing how much we're still really in the background. Now, HIV did wonders for transparency about public health surveillance. The fight between HIV infection reporting versus age reporting and name-based reporting versus unique identifier reporting did a fabulous job for us, because we spent at CDC, I alone probably did 100 outreach events with affected communities, telling them about what surveillance was, why we did it, what the protections were, and getting people to say, oh my God, that's a good thing. Why did I think that was a bad thing all this time? And they start to understand it. So now we have a whole, generation of people affected by HIV who get it with respect to why the data are important. But mostly we just hang out in the background and try to apply it. No, right. We have a cohort and now they're aging and they're going to be done. Now we got to start over again. So our work never ends, right? So